case I forget, use a ring in 100%. I guess the only time that I don't use a ring would be if I'm doing a hokum patient, and occasionally then I will do an Alfieri through the outflow tract, just as almost a belt and suspenders approach to it. I'm not really going to talk much about rings themselves. I'm going to talk more about how you size it, a little bit about suture placement, avoiding SAM, and then planning ahead for the possibility for, just in case the disease comes back, the patient needs a valve and ring. I actually started about 12 years ago actually measuring the valve leaflets in multiple segments. Instead of using sizers and all, I actually have calipers, and then also now I have the echocardiographers measure the anterior leaflet length. Since much of our decision about sizing of the annuloplasty ring is dependent upon the length of the leaflets, it seems that we ought to be more precise than trying to jam that sizer in through a really small incision and trying to line it up. So I want to know exactly how tall it is. I reconstruct the leaflet so that it is to the usual 2-to-1 ratio, so that the anterior leaflet on average in degenerative MR in our experience was 28 millimeters. The posterior leaflet is usually very tall, about 22 millimeters, and we'll talk about that when we talk about artificial cords. And I'm a resection guy, and I make the posterior leaflet half of the anterior leaflet at 14. I do a little bit of split the difference between triangular resection and a quadrangular. I don't do a quadrangular virtually ever anymore because I don't like to distort the annulus that much, and so it's more of a kind of a trapezoid in some of these patients. This one I'm bringing because 20 years ago, David Adams and I talked about when we were starting out, he had a patient that he put the suture, actually I think you blame the resident, David, and putting the suture through the leaflet. And this is to point out, don't use the color change over here. Look for the annulus itself. In fact, this is important. So for those who are starting out, I'm going to back it up a little bit again and then show this. Or maybe I'm not. But the color change doesn't really align over at the base of A1 with where the annulus is. So I usually will pick up the pickups and pull it up and down, and you may be off by about 4 or 5 millimeters. David, I bet you remember that patient. Then you size based on the A2 length or height, and I have a very simple way that we do that. In terms of which ring to choose, Steve Bowling says it's not the ring, it's the ringer, or in golf, it's not the club, it's the golfer. You could give any of those pro golfers a 5-iron or a 7-iron or a 9-iron, and they'd probably be able to play most of the courses and par almost all the holes, and it doesn't matter to them which type of club that they're really playing with, except to get it 10 under par. But for most of us, it really is not so much about the different types of ring for degenerative MR. I happen to use Physio 2, and since I'm sizing based on the height of the anterior leaflet, you roughly take the A2 height and then add 10. So if I have a 26 millimeter roughly anterior leaflet, add 10, 36 ring is going to add up to that. I like to think about it from the side view. It's almost like the echo view. As the surgeons, we're looking at it en face, but really you should be thinking about the amount of coaptation. And Professor Carpenti, I used to say that you should look for 5 to 10 millimeters of coaptation when you're done. So if you do the simple math, and Steve Bowling is a math boy, so double check this, Steve, but if you have a 28 millimeter anterior leaflet, you've made the posterior 14, that's 42, and then when you put in a 28 millimeter or 38 millimeter ring, then you're going to have the coaptation length is going to be exactly half of the posterior leaflet, and we've actually checked this multiple times. In fact, it got so routine that we stopped doing it a few years ago. But the coaptation length that they talk about with the artificial cords versus resection and stuff, as if, well, the artificial cords are increasing coaptation. No, they're not. All it is it's about the size of the ring that you're putting in and then how much you pull down the artificial cords. If you put in a really small ring, you're going to get a lot more coaptation. If you had a bigger ring, you're going to have less coaptation. And if you look at the difference in those sizes, I'll back up on those rings. It's only like a couple of millimeters or less per ring, so people perseverate about whether it's a 32 or a 34 ring and stuff. It's really going to be a minimal difference when you split the coaptation in half. This is an example. If you put a 30 millimeter ring in and it was 10 millimeters posteriorly, it's 5 millimeters. How do you avoid SAM? Again, David had written this years ago, and this is really pretty much true, I'd say. Either you left the posterior leaflet too tall or you put a ring in that was too small. The number that I ask for every case is this C-Septum, the coaptation point to the septum, and it should be over 25 millimeters. So I always have the anesthesiologist measure it. This one is 3.8. There's going to be very low risk for having SAM. Here's an example. So it's a 28 millimeter anterior leaflet, and they put in a 28 ring instead of a 38. So what you're going to have is a whole lot more coaptation down here. You're going to have 12 millimeters of coaptation. And then if it happened to look like this, if you're seeing 50% anterior and 50% posterior, you're going to end up with SAM, because what you have is a lot of this anterior leaflet is going to be redundant and it's going to be available to create outflow tract obstruction. The artificial cord team also talk about that you can use larger rings, but I'm a resection guy and I use larger rings. If you look at, kind of the middle of the bell-shaped curve is around sort of 34 or so. And so you can put in the bigger rings, and in fact, that's almost always what I use. It's unusual that I would use anything that is as small as a 30 with degenerative disease, and that would probably be an older patient that had fibroelastic deficiency. If you are using artificial cords, just be a little careful. You have to accommodate for the excess height and the volume. And so how deep you pull this in, if you have a really big, like I showed here, an average 22 millimeter posterior leaflet, you might want to pull that way down into the ventricle so that you don't end up with too much leaflet. But this does take a little bit of judgment, as I mentioned before. There are minor variations. It's not always exactly on. If the posterior leaflet happens to be less than half, like P1 and P3 are usually not as tall. And after resection, if the whole thing is a little bit less, I might go down by one size. Or if the C-Septum is a little bit too short, 25 millimeters, might go up or a little bit. Or if the posterior leaflet, I try to always leave it less than 25. So the last point is just kind of plan ahead. This is from Myra Guerrero, writing about a year ago, and she's talking about valve and ring and how challenging it is. She says, don't use flexible incomplete bands or very rigid, because those are really difficult to treat later on. Think about a ring with the future. Tyrone points out how with the 20-year results, it looks very good, the freedom from reoperation, but there was a fair amount of patients that were developing moderate. So if you operate on a 55-year-old, when they're 75, they may need something. And then these are our results, 10-year freedom from, this one's re-op at 99.7, and from moderate to severe or severe at about 98%. Summary, size by the length, use bigger rings in general, make the posterior leaflet about half or less than 15, measure the C-Septum. Thank you.